Hello, good evening, everybody. Thank you, Sue, for that. I'm hoping you can hear me okay. It's a bit lonely sitting in a bedroom and suddenly talking to lots of people and not knowing if they're really there. So yeah, thank you very much, Sue. We are, I did hear at the beginning of the presentation that there are lots of people from all over the world. So where's Durham and Darlington? Well, it's where that little star is on the map of Britain. Whilst it looks very small, we cover quite a large geographical area, as we said, covering just under 5,000 births a year, but looking after about 7,000 families. So a little bit about the sort of the team we work with. We've got 262 midwives, 10 specialists, and actually it says, well, I'm one of those. This was written by Amy, who I'll give a big shout out today, who's our continuity carer lead and is the most passionate person that I think I've come across for a long time. We've got some fantastic matrons. We've got 3 matrons as myself and 21 consultants. We cover 2 large acute hospitals and 3 community hospitals as well. So it's a really big patch that we cover. This is sort of a generic presentation, so I'm not going to go into sort of the research behind why we're doing continuity of care. And I think Sarah covered so fantastically a lot of sort of the drivers around deprivation and BAME and why we need to do something differently. This presentation is more around a little bit of a different sort of aspect of continuity of care. Again, there's just a few of the sort of the drivers around why we're doing it. But this presentation is very much more around sort of the workforce and the journey we've taken in County Durham and Darlington, which we might say is brave, we might say is scary, but truly believe that it's the right way to go. So I'm going to just take you through a little bit about our sort of presentation. And we had to really talk to our execs and some of our staff and remind ourselves why we're doing it. So forgive me for all the midwives on the screen that know how oxytocin works, but people say, well, why? Why does it work? So we all know that when people come into hospital and they're scared and they're absolutely past themselves, and I know you all know this, but it's just reminding ourselves of why it's so important that people have to tell their story. People have that fear hormone, adrenaline top trumps oxytocin. And, you know, how many times have you heard people arrive on delivery suits and say, well, I had loads of contractions at home and it's all gone off. You know, there's a little bit of truth in that and why. And actually, when you've been, I'm not going to, sorry, I can absolutely share these slides, but I just think it's quite important to get on to the next bit, which is a little bit about the workforce. But actually, it works because people build a relationship, and it's that that bonding theory, it's that belonging theory. It's because people know each other. So somebody said to me once in our LMS, can all midwives put their hand up if they ask a friend to look after them in labour? And a lot of people put their hand up because actually they get looked after by somebody they care for. And we should trust every midwife that we work with. And we absolutely do. And I would say as heads of midwifery, we have to look at the staff that we work with and say, could anybody in your service deliver your daughter? And the answer should always be yes. But actually we do like to have somebody that looks after us, because it's about that relationship, because we don't have to tell the story, because we don't have to tell the story that the ex-husband's a wally or his mother's a pain in the bottom or nearly, or you know, what that sort of safeguarding story is behind it, and actually the trauma that may go back in people's histories, because that can make a huge massive difference to that building the relationship at such an intimate and personal time. And that's what makes the difference. So where are we going with this? Well, 6,000 women, we've got a vision, we've got a strategy and a plan. And actually, do you know what? Every one of those 6,000 women deserve this care. They deserve the better outcomes. They deserve the psychological security, and they deserve to have those huge differences to sort of the public health, the smoking, the breastfeeding, and actually been feeling loved and cared for throughout their journey. And this isn't to say that the care that is given presently is not great. It is. Every midwife does the best they can. And I think it was maybe on was it last week's live podcast of this, it was somebody talked about the zombie midwife, and that was just so accurate, because how many times do you speak to midwives that are just burning out, and it just can't continue. And how can you give good care when you really are sort of on the edge of your seat on a daily basis? So the journey we've taken, and I'm not going to focus too much on the detail, I just want to take you on the journey that we've been through so far, and we're not at the end. The journey's hard and there's some really big bumps on the road, and I think we hit a bump on a regular basis, but it's how we get over that bump or around that bump. So we had an idea, and the idea was that in Durham and Darlington we only have 6% BAME population, but you know what, we have huge amounts of deprivation. The deprivation within Durham and Darlington, we've got huge amounts of pit villages where we've got sort of historic deprivation, we've got huge amounts of high smoking levels. There is a significant drug use. There is quite a large amount of artificial feeding, but then we've got pockets of real good, the university city of Durham, where we've got international students and some really affluent areas, all that come with their own challenges. So how do you approach all of that? But again, I go back to every woman deserves the best possible care we can possibly give. So we were really on the naughty step in Durham and Darlington for a while, and I think with the bane of our regional LMS's life, because we were presenting really low rates of continuity of care, because we just couldn't understand how we could do it. And as many people say, how can you do it without huge amounts of resource? So we were really on the back step, and we were really getting flagged sort of from a regional basis of, come on, you need to get your act together, really. This isn't working at all, and you're not going to meet any of the targets, and you need to just really take stock and sort this out. So in a darkened room one day, we really had to think about it, and it was the time when Tracey was launching her strategy around the workforce, and actually going back to that challenge. You can do it with the workforce you've got, you just need to do it differently. And I wasn't a believer in that, but took a long, hard look at how we could do it. And one dark night decided to be really brave and really cheeky and email Tracey and say, I can't do this, can you help me? And so she said, are you free now? Whoa, really? So we went on a Teams meeting at 6 o'clock one night with a Christmas tree in the background, and she talked me through it in detail with the staff establishment that I had, and I was really, really honoured and lucky to be able to do that. And suddenly the light bulb turned on, and my daughters even heard me go, yay, I think I've got it. And that was sort of the beginning of the journey. So it took 6 months to put a strategy together. And what we decided to do based on that strategy was, we need to do this for all of our women, and it's going to take a lot of teams and it's going to take a lot of time. But what we realised was that we need to mobilise the whole of our workforce. And if we do it on a small basis, then it's not going to create the effect for the whole workforce. It's not going to make a difference. So we decided to, when I say decided to, I didn't want to, but from speaking to sort of staff side reps, we kind of decided it was the right thing to do, to go into consultation with all of our midwives. So we've actually consulted with all of our midwives, which was, I'm not going to lie, the hardest possible thing in my career up to now. And that was around staff engagement. We did over 130 one-to-ones. We did over 23 evening team sessions, and this was during COVID. And we had lots of meetings with the RCM that were very, very interesting. And the take-home message was, at that point, engage, talk to staff as much as humanly possible, because I didn't get it right at the beginning. I didn't talk to as many staff. I made the mistake of thinking if I send a strategy during COVID, people would read it, and they didn't. So actually, I got it wrong at the beginning, and I think we learn every day, and and I continue to get it wrong, but I continue to build on it with the team that are awesome. And I suppose the shout out is, it's the team that are around you that make the difference, and this isn't something that one person can do alone. So I suppose from a workforce point of view, the biggest bounce back I got was, yes, we all know it's great, and we all know it's going to be good for women, but actually we can't do it with the workforce we've got. And this is just kind of, we've got a couple of these slides, and it was kind of like going back to but it doesn't work now. Every day when I go on labour ward, or when you go onto one of the units, if we say, how's the workforce? We're 1 down, we're 2 down. At the minute, it's often 3 down. And actually, what does that mean? Are we 3 down, or is it because actually our rotas say we're 3 down? So if we've got 12 people in labour or 3 people in labour, it is that sort of language around, it doesn't really matter how many we've got, we're staffing a unit, and if we are supposed to have 6 staff on an early staff, if we've got 5, we're 1 down. If we've got 7, we're 1 up. But actually it's regardless of the amount of women that we've got on labour. Bear with me, I'm hopeful this will make sense as we sort of move through. We report on a monthly basis to our director of nursing and our board about, and I'm sure all the heads of midwifery and sort of senior staff on the call will be very familiar with this kind of pie chart and the outcomes basis around staffing. So what that demonstrates to you, and this is a little bit old now, but back in February 2021, at one of our units, we were only meeting safe staffing really well for 49% of the time. And in the other unit, 67% of the time. 25% of the time in one unit and 36% of the time in the other were on the edge. And the red areas, the red parts of the pie chart is where it was not great and it was probably unsafe. And we didn't have enough midwives for the women we're caring for. And that's because there was not enough midwives for the activity that we had. I'm just going to kind of go on to the next one. But actually, if we think about the variation, and I'd imagine the majority of people on this call are practicing midwives or midwives that have practiced recently. And we've all been on, not so much recently, and I absolutely get that, but we've all been on shifts where we've had a fluctuation in activity because actually we're not a surgical unit. We can't bring the activity in, bring patients in for the beds that we've got. The women, funnily enough, but not all of them because a lot of them are induced now, but women tend to come when they're ready to come. So this gives you some data about from November to March last year of how many times across both our units we were either had three midwives too many for the women that we've got from an acuity point of view. Bear in mind, if you have a low risk woman, you should need 1 midwife to care for her. If you have a high risk woman at the very possible high acuity, is 1.4. So if we've got 3 low-risk women, we should need 3 midwives as a very basic example, and most people, I'm sure, get that. You know, we always prioritise the hospital and we always look at the acuity on the delivery suite, and one thing that we've thought about very much recently is the delivery suite pulls from postnatal, delivery suite pulls from the assessment unit, and we maintain that acuity. But actually in the community, we've really worked with caseloads that are far above what we should be doing for a long time. So our caseloads have been about 110. That means that women are getting 15-minute appointments antenatally, that midwives are throwing safeguarding reports in at the end of the day when they've had a huge amount in their diary. And this is a real diary entry from March earlier in the year. It's not great. It's not good quality. The midwives are working hard and they're giving good care, but not the best care they could. So on a daily basis, this is how it feels. And it probably even feels worse than that now because everyone's tired. The bank fill rate is reduced. People don't want to do extra shifts and people are tired, and we've got a national staffing crisis. So there's peaks and troughs, and it's probably the downward scale that there's a majority at the moment. And that's how staff feel on a daily basis, going, is it going to be okay? Is it going to be horrific? Is it going to be okay? And that's how it is. So actually what we're doing on a daily basis, and this is the chart I showed you before about perfect staffing. So in an ideal world, we're going to be in that perfect staffing state all the time, because if we've got perfect staffing, we've got a healthy workforce, and the performance of those staff is at just the right stage. If staff are, not that we get this nowadays, but if they don't have the activity coming through and we all are stood around the desk, we're becoming active and bored, and the performance isn't great either. And then we get to the other stage where we actually are having far too many women to look after than the midwives we've got. We're working towards the right-hand side, which is burnout and breakdown. Our performance plummets and our health absolutely takes a nosedive. So the more we're under stress and the more at the right side of that bell curve, the more mistakes we make on a daily basis. So what I'm trying to say is that staffing at 21% in the acute equals staff and decreased performance. It doesn't work. What we've been doing for the last year, for the last 5 years, and I would challenge people on the call to say, so 6 years ago, did we complain about staffing? For anyone that did off duty 4 years ago, did you have gaps in your roster? And the answer I would suggest is probably yes. So we keep plugging gaps, but the gaps still will appear. Women get more complex and our gaps will continue. We have to kind of stop this journey. And I like it a little bit too, we all keep talking about a journey, but you know, it's a little bit little bit like being at a bus stop where no one really wants to be there, and it's really hard work, and it is really horrible being at that bus stop. But we're not really brave enough to get on the bus to get to the next bus stop where actually we know that life's going to be a bit better. And the bit we're at the moment is very much where we're trying to load the bus, but it's about getting the people on the bus, because even though they don't like where they are, it's really hard to leave it. So at the minute, we're staffing a unit, we're not flexing for women. What we really need to do is a model where we need to move where the work is. So if we've got a labour ward full of women, we need to be able to flex up the workforce to be able to look after those women and give them the care they deserve. And when we've got a labour ward that isn't as full as women as we maybe have on other days, is that care is delivered in the community where the women deserve that care antenatally and postnatally. And that's not a 15-minute appointment. That's something much more wraparound care around those women. So I don't even know if I dare even say this, because I can get a bit tongue-tied. So if we have a core group of midwives on the delivery suite, and then we have teams of women midwives in the community that are looking after reduced caseloads up to 36 to 42, as we do in the continuity models. We've got Susie from Stanley being looked after by an Infinity midwife. And I apologise, Infinity is our brand. It's our brand for so much as Sarah's got the different trees. We went for Infinity across. It's care that continues. It never stops. So we have an Infinity for Stanley, an Infinity for Ferry Hill, for example. So Susie from Stanley would have her Infinity midwife or her team come and care for her. Penny from Pelton would have her team come and look after her. Fingers crossed. Franny from Ferry Hill would have her team come and look after her. But Debbie from Durham team hasn't launched yet, so she'll be cared for by the core team in the hospital. So the top half of the infographic there is our base staff at the moment. So at the moment, you can see that we've got a number of staff on the Durham unit, slightly more, and on the second late row down, it's the staff at the other acute unit. There is a maximum amount of staff. There's nowhere to go to unless we start calling us as a kind of a management team. In the middle of the night, that's it. There's no one else. You're stopped. But actually in Infinity, in the future, when we have all of our teams out, you'll have a core group of staff on one unit, a core group of staff on the other. And because we've got 17 teams out, in theory, across the whole of our geographical area, you can call in 17 birth availabilities. So suddenly going from a core group of a maximum of 20 staff around on night duty, you've suddenly got 28 staff on night duty. So there's more midwives available to provide the care and to flex the cover of the care as the activity requires. I'll not go much on that, but that's how the future is, and that's one of our pilot teams and how their life is and how very different it is. I suppose what to say is that they're delivering hourly antenatal appointments, which is very different to 15 minutes. And the question the staff said to me was, well, how is it safe? This can't be safe. You can't send all those staff into Infinity and have a core group of staff in the delivery suite and it still be safe. So what we did was look at the birth rate plus ratio as those teams went out, and this is in the acute. So if we look at the birth rate plus ratio, I've been 1 to 38 across the whole of the service. You can see there at Durham back in November, we weren't really meeting that. It wasn't particularly safe. It was slightly above the ratio that we would aim to go through. Darlington was a little better state. But as each team goes out, and as each team takes their, in theory, look after take their 280 women per team with them, the birth rate plus ratio comes down to a very, very sensible level as we move forward. But what about traditional community? We've got a bit of a blip there because one of our teams straddles both of our acute hospitals, but essentially it goes down a lot lower. But at the minute, or at the beginning of this journey, our caseloads are about 110 to 120. And as time goes on, they go down to the 1 to 42 as we all move to Infinity across the whole service. So we know that continuity of care is fantastic for women and families. Sarah talked about that. But actually, it's got to be better for midwives. We can't carry on this roller coaster of having horrific shifts on a daily basis, and community midwives that just can't cope with the amount of caseloads we've got. So we've got to move to something different. So we're moving towards infinity over 17 teams. We have at the present 3 teams out. We've got 2 more going out. So by the end of November, we'll be looking after 840 women in infinity. The outcomes speak for themselves. These are very early outcomes. Sorry, I'm just going to one screen. I don't know if I can. But what we've seen in one of our most deprived areas are women that have been smoking. We had about a 45% at delivery smoking rate when they started, and they got down to 12% by March last year. And that continues in the outcomes that we're having already. We're looking after 90% of our women in our teams at the moment, and our normal delivery rate is well above what we had previously. So the outcomes, we're about to launch our 1-year report, which will cover the 3 teams and the 2 teams that are coming on board. And our rollout is going to take another year. There's some lovely pictures. But I think what I would say is that's our end slide around bring your labour bag, bring your notes and bring your midwife. However, what I would say just kind of as a very end point to this, that this is not a happy journey. It will be a happy ending, but it's a real struggle. And certainly as a head of midwifery, what I would say is this journey is really, really hard. People don't want to get on the bus. The change process is huge. People are really struggling with the concept. People are we've got people in the teams that are loving the concept and are saying, I've never felt it better as a midwife in my life. It's wonderful. People didn't want to go out there, but it's really, really hard. Thankfully, I've got great support from Tracey and Tracey, who are also coming up to, in November, a drop of a hat, thank God, the Lifesaving are coming to help me with some challenges that I've got in Durham and Darlington, and the team that we're working with very closely. It's really, really hard, but we have to keep going in the direction, because if we go backwards, we're not going to improve things, and we're going to go back where we were 5 years ago. So that's kind of our journey up to date. I hope that helps, and any questions, great for receiving.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.